Welcome to a lecture on the complications that can be associated with IV therapy. So, with IV therapy, there is a risk for complications, and we're going to go over the different common complications. And we have them divided into two groups, local complications as well as systemic complications. So when you're administering IV fluids or IV medications to a patient through a peripheral line, you want to be alert for signs and symptoms of complications, and you want to make sure that you are doing everything you can to prevent complications and be ready to intervene if a complication does occur. So we're going to talk about each of these in the following slides. So like I've already indicated, complications are classified into two groups, being the first being local, so the complication is usually around the IV site itself, either at the site or near it. And then the second type of complication, which is usually more serious, is systemic, and that means that the complication has occurred within the vascular system, remote from the IV site, and that can be quite serious and life-threatening. So the first complication we're going to talk about, I'm sure you've all seen before if you have experience with a patient who has had an IV, or especially with their older population, they're a little more at risk, is a hematoma. So a hematoma occurs when there's leakage of blood from the blood vessel into the surrounding soft tissue. This can occur when the IV catheter passes through more than one wall of the blood vessel, or if there's too much pressure being applied at the IV site. Also, if there's too much, if you're not applying pressure when you remove the IV cannula when it's being discontinued. Hematoma can be controlled with some direct pressure, and they usually heal and resolve in about 2 weeks. Applying a tourniquet too tight can also be a risk for a hematoma. And with our older population, often their veins are more fragile, and you may need less pressure, so the tourniquet might not need to be as tight. Sometimes you can use a blood pressure cuff pumped up instead of a tourniquet to assist with finding the vein but not putting so much pressure on it that we may put them at risk for a rupture of the vein and a hematoma. So signs and symptoms are obvious: discoloration of the skin, a little bit of site swelling, maybe tender discomfort, and there may be an inability to advance the cannula all the way into the vein during insertion when this happens, if this happens during the insertion process. So the next complication we're going to discuss is phlebitis. Phlebitis is a really common complication. Actually, I read patients, clients with IVs, 80% of them have symptoms of phlebitis. So this one's very common. So phlebitis is quite simply inflammation of the vein. It's usually associated when you're using really acidic or really alkaline solutions or medications that have a high osmolarity that's different from our normal body plasma. Phlebitis can also occur as a result of trauma to the vein during the insertion. It could be because you're using an inappropriate size of catheter for the size of the vein. So you always need to look at the catheter that you're putting in and the approximate size of the vein and make sure it's going to be adequate to fit it. Or if we're using the same IV site for too long. So usually with phlebitis, there's going to be some swelling, some tenderness, some erythema, some redness around the injured vein. So it may look red, it may be warm to touch, it may be tender to touch, it may be a little swollen. So some prevention tips for phlebitis is to always use proper venipuncture technique. You'll learn about venipuncture in 4th semester. Use your drug reference guide and pay attention to the dilution criteria as well as the osmolarity of the solutions and medications we're infusing, to be mindful if peripheral short IV is the most appropriate device for your patient, or if we should be looking at a midline or a central line like a PIC. Monitoring the IV rate of infusion and inspecting the IV site frequently, and also changing the IV site according to policy or when there's any signs of phlebitis. Another local complication is just an add-on to the phlebitis. It's a superficial thrombophlebitis. So you guys all know what thrombus means. Thrombus means a clot, and thrombophlebitis is caused by microorganisms getting into that vein through the insertion site. Maybe there was poor technique used when it was being put in, or it was put in during an emergency. Maybe there wasn't adequate hand hygiene, and somehow microorganisms have gotten in, and then a clot develops. So it's inflammation of the vein with a blood clot, and the signs and symptoms of this are the same as phlebitis. So it's warm, red, tender to touch, but it will also be hard because of that clot, or you might even feel a cord, like a hard long cord, a cord like a feeling. These are dangerous because there is potential that they could result in an embolism in that clot traveling. It would be rare, but it is a risk. So what should you do if your patient has a superficial thrombophlebitis? So you want to remove the IV device as soon as there's signs and symptoms of phlebitis or thrombophlebitis. Apply warm compresses. Restart the IV if they still need it in a different extremity. Report to the healthcare provider and document thoroughly about your assessment and your interventions. I guess I talked already about how to prevent a phlebitis or a thrombophlebitis, but always ensuring we have proper infection control. Hand hygiene is essential. Cleaning adequately, allowing the area to dry, and not recontaminating it before you insert the catheter. Always have the date and time on the IV site. Rotate sites as per policy. Always be paying attention if your vein is too small for the size of the catheter needed, or the strength of the medicines and solutions, like I've already said. And also making sure that you're always able to see your IV site. So it's recommended that there's a transparent dressing on that gives you full visualization of the site, so that you can pick up on phlebitis as soon as the symptoms arise and signs. So this is the phlebitis visual infusion phlebitis score. This in phlebitis scale is in your textbooks. It's in your skills book as well as your hardcover fundamentals book. And this scale is used in most hospitals across the country, and it is recommended as the scale to be using when you're measuring phlebitis. And it also gives you the interventions. So a phlebitis score of 0 would be healthy IV site, no signs of phlebitis, continue to monitor. A scale of 1 would be one of the following is evident. So there could be some pain and there could be some redness around the IV site, one or the other. So you're thinking with the pain or the redness, this may be a sign of phlebitis. So you're on caution, you got the yellow light. You're watching closely. Phlebitis score of 2. You have two of the following. So number 2, you have 2 symptoms. So there could be some erythema, some redness, there could be some edema, and it might be getting a little pale near the IV site as well. So that's an early stage of phlebitis, and the intervention is discontinue that site and restart it somewhere else if it needs to be continued. A phlebitis score of 3, all of the following are evident. So there's pain along the path of the cannula, redness, and induration. And that's a medium stage phlebitis, so you want to resite your cannula and consider some treatment. Number 4 is all of the following are evident and extensive. So there is pain along the cannula, the path of the cannula. There is that erythema, as well as the induration and the palpable venous cord. So induration, by the way, means like there is some loss of elasticity and pliability of the skin, so that there's some hardening. Induration means there's some hardening of that soft tissue, and then palpable venous cord is like there is a hard cord-like feeling inside the site. And then number 5, so the interventions for that are to definitely take it out, resite, consider treatment. And then for number 5, you got pain, erythema, induration, the cord, as well as a fever, pyrexia. And again, initiate treatment and resite cannula. And the doctor, the physician may want blood work and may want to order antibiotics for a stage 5. So these are just a visual of the common complications. So you got the phlebitis over here, which is an inflammation of the vein. In here we got the infiltration, where you can see that the cathlon has pierced through the vessel, and now the fluid that's being administered is escaping out into the tissues rather than inside the vessel where it's meant to be. And thirdly, an occlusion. So we got some clotting going on around the end of the cathlon. So now we're going to talk about infiltration. Infiltration is a very common complication as well, okay? So phlebitis and infiltration are your 2 most common complications. So infiltration is often called in practice as the IV tissued. You probably heard people say, if you've been around IVs, oh, it tissued, or the IV tissued. But the technical term would be infiltration, or you're going to also hear about a word, extravasation. So both of those words, infiltration or extravasation, refer to the fact that we have accidentally administered fluid into the surrounding tissue instead of into the blood vessel where it was meant to be. So there is escape of fluid from the vein into the surrounding tissues. The catheter has dislodged from the vein. It's not in the vein anymore where it's supposed to be. And this can happen on insertion, so you think you're in, but you actually went in and then busted through the side of the vessel, and then you've put your flush in and it all goes into the tissues instead of inside the blood vessel into the circulation where it was meant to go. So as you can see from the pictures, it causes swelling around the tissues where the fluid was administered. And I'll just flick the slide here and we'll talk about the signs and symptoms. So actually I'll stay on the picture because you have a visual here. So the signs and symptoms are, there's usually going to be puffing up of the hand or the arm or the foot or wherever it is. And if it's a child, though, they're like less likely, or someone who has some cognitive impairment, or an older adult with less sensation, they may be less likely to notice, or with a newborn or a child, oftentimes it does swell up quite a bit before it's recognized, because they're not able to communicate so well. So this is why we need to be checking our IV sites every hour, and have a good visual with a nice transparent dressing. So lots of edema with infiltration. The longer it's infiltrating, the more the edema is going to expand. Coolness around the site, that's from decreased circulation. Some pain or tenderness, all related to the edema. Some pallor of the skin, and when you check your IV site, like you draw back to see if it's in the blood vessel, you're not going to get fresh blood. You're going to get like a light pink, or no backflash at all. Like, you're not going to get any fluid back when you draw back on your IV. Yeah, I think I discussed all of the symptoms. So just remember, a lot of swelling around the insertion site. Skin may feel cool. That's because of the fluid going in, as well as the lack of circulation. And most of the pain is related to the tightening, the swelling. So moving on to treatment. So the management is stop the infusion and discontinue the IV. First step, remove the device. Elevate the limb to try to increase patient comfort and increase venous return. A warm compress may be applied. You want to check the pulses and cap refill time. You want to start the IV in a different location, preferably a different limb, and restart the infusion elsewhere if it needs to be continued. Check the site frequently to make sure that the edema is decreasing. Document all of your interventions and all of your findings. So you want to promote venous return and promote circulation, and make sure you stop that fluid as soon as this is recognized. For prevention, using an appropriate IV site, trying to avoid areas of flexion where it's going to get bumped and banged around. If it's being bumped and banged around, it's more likely to dislodge through the vessel, right? Also using good securing equipment. So, taping it properly, using a good transparent dressing. There is devices that some facilities use that secure the IV. They are recommended by the INS standards. I haven't seen those much on Prince Edward Island, but things are always changing. Advise and educate your patient to report any swelling or tenderness at the site. If it's a child or somebody who isn't able to monitor it, you need to be doing more frequent assessments and documenting all of them. So the next one is extravasation. So extravasation is the leaking of fluid into the surrounding tissue that is vesicant. So a vesicant solution means that it's very irritating or damaging to the tissue. So it's the unintentional leakage of vesicant solution or medication from the vein into the tissues, and it is a medical emergency. So Extravasation can cause severe tissue damage, possibly leading to delayed healing, infection, even tissue necrosis, so death of the tissue, disfigurement, loss of function, and even amputation in worst case scenario. There's often delayed reactions with an extravasation, which is concerning. It may not happen right away. The biggest symptom and first symptom is the patient telling you they're having burning or stinging at the site of administration. Patients who cannot communicate, like newborns or cognitively impaired, are the most at risk for a extravasation. So these are some vesicant medications or solutions that I just wanted to bring your attention, because I know you've heard of some of these drugs. So fluoroquinolones, gentamicin, penicillin, vancomycin, calcium chloride, potassium chloride, TPN, cytotoxic agents, sodium bicarb, dextrose, in greater than 10% dextrose, Valium, dopamine, contrast agents used in radiology, dilantin. Okay, so these are just some. There are so many more, but I just wanted to bring to your attention quite a few antibiotics are vesicant. Also, high amounts of dextrose are, TPN is. So back to earlier lessons, that's why sometimes a central line is safer and preferred for some solutions that are vesicant. So with TPN, we generally want a central line where we have better circulation and not put our patients at risk for extravasation. So the signs and symptoms, I guess I already talked about that. But the interventions for an extravasation are to stop the IV immediately, clearly, and remove the IV line. You want to get a hold of the physician ASAP. There may be some antidotes that could be provided as per facility protocol. Elevate the extremity. Perform frequent assessments of motor function and sensation of the affected limb, and make sure there's good, adequate circulation. Record the extravasation situation, record all the patient's symptoms, the estimated amount of solution that we think was extravasated, the treatment you have provided. All of your documentation is super important, okay, because this may end up in an investigation. And follow the policies about whether to apply a warm compress, or sometimes they might want a cold compress. Some prevention for extravasation I've already kind of hit on, but avoid veins that are too small or too fragile. Avoid veins that are in areas of flexion where that is going to be more likely to pop through the vessel, the cathlon. Avoid areas that have pre-existing edema. Be aware of what you're giving. Don't be careful if you're giving vesicant medications. Watch more closely. Consider putting in a different line, a different device. So what to document, I think I already went over all that, so we'll keep going. And now we're moving on to another local complication could be an infection at the IV site. So some microbial contamination of the cannula. It could be like an infection of Staphylococcus. Might have entered when it was being put in and got into the circulatory system a little bit. Other bacteria such as staph or fungal infection. So you want to watch your site for redness, swelling, any yucky, purulent drainage, monitor blood work for increased WBCs, and an elevated temperature would also be a sign that we might have a systemic infection. Systemic infection, known as septicemia, is a febrile disease process that results from microorganisms getting into our circulatory system. So like I mentioned, it could be staph or it could be strep or something like that. So signs and symptoms of infection include there could be that localized erythema, reddening of the skin, pus around the IV site. There could be warmth to the area and pain. Then throughout the body, if it's a systemic infection, we're thinking about a fever, fatigue, tachycardia, low blood pressure, shock, death, altered level of consciousness. Septicemia progresses very rapidly. Altered level of consciousness and changing vital signs are probably your biggest indicators. So doing accurate assessments and comparing to your baseline is essential. Interventions for sepsis, we need to get a hold of a physician ASAP. We need to start intervening with the problems, symptomatic care, try to get to the source of infection, remove the IV if we're talking sepsis from the IV, we're clearly going to remove it. We would like to get a CNS of the cannula at the lab. And so you might want to hold on to the IV that you remove and the tubing in solution for some cultures. Establish a new IV site because they're going to need medications and fluids for a sepsis for sure. This is a bit of a critical situation, so you're probably going to need to be consulting and working with other healthcare providers. They're probably going to need blood work as well. Another systemic complication is fluid overload. So circulatory overload can occur when fluid is given too rapidly. This can lead to all kinds of cardiac and pulmonary issues, pulmonary edema, congestive heart failure, shock, cardiac arrest. Particularly our patients that are older are more at risk, and those with impaired renal function or cardiac function, as well as our little people, our children and babies are at a risk for pulmonary fluid overload and pulmonary edema. So paying attention to our infusion rates, making sure they're accurate. Also paying attention to what types of solution we're given. Isotonic fluids and hypertonic fluids, we know, stay in the circulatory system. With our hypertonic, it's drawing the fluid out of the cells into the extracellular space. So you want to be watching your patient very closely and consulting our other healthcare providers if we're seeing any problems. Also, if we give fluid too fast in someone who's compromised, that can also be a reason why our patient can end up with this complication. So signs and symptoms of fluid overload, pulmonary edema, is restlessness, headache, tachycardia, weight gain, coughing, edema, crackles on the lungs, breathing difficulty. So to avoid circulatory overload, an infusion device, an electronic infusion device instead of running your IV on gravity would be essential so that we make sure we're giving accurate prescribed rates. Having good sound knowledge of your fluids and medications and making sure we're always giving the correct rate that would be appropriate for the patient that's in our care. So let's say you had a patient back that had a very minor surgical procedure like a bladder repair, and maybe the IV is going at 200 mils per hour, and maybe it's even ordered like that in the chart, and that would be a very fast IV rate for a straightforward surgical post-op patient. for a post-op patient, you would expect their IV to be running for an adult, anywhere from 75 mils per hour to maybe a little over 100. So if it was going at 200 mils per hour for 2 or 3 hours, that's 600 mils. That would be a large amount of fluid if everything went well in the operating room. So it could have been an order put in error. So you want to start paying attention to what the normals are, and then intervening and saying, did you really want this IV running at 200 mils per hour? And they might be like, oh my goodness, no, I meant to say 50 mils per hour. Like, I don't know how that happened. So using your clinical judgment is really important. Lastly is another systemic complication, an air embolism. And an air embolism is when air is introduced into the blood through the IV equipment, the IV tubing. And signs and symptoms are complaints of heart palpitations, weakness, difficulty breathing, turning blue, wheezing, coughing, feeling like their lungs are filling up with fluid, might hear heart murmur, pulses may become weak, fast, chest pain, jugular vein distension, change in the level of consciousness, confusion, and anxious. So this is most certainly a medical emergency. So this happens if a large volume of air enters the patient's vein via the IV tubing. And most IV tubing holds around 13 mils to 15 mils of air. Okay, so if you think about a 20 cc syringe, the tubing holds like a little over 10 cc's. So generally people can tolerate more than that amount of air. It's dependent on weight. So it's our small children and babies that are most at risk for this. Luckily, this is an extremely rare complication because we prevent it by making sure that all of our tubing is primed and there are no air bubbles. So the nursing interventions, if a patient was to have signs of an air embolism and somehow got a significant amount of air infused into their circulatory system, you would immediately clamp the tubing, monitor the vitals, administer oxygen, call for help, document. And yeah, we definitely prevent this by flushing everything, monitoring our tubing, and making sure all our tubing is primed, and avoid administering air into your patient at all costs. So these are just some tips for preventing complications. So always assessing your solutions, following your 10 rights, and observing your IV sets. Quick quiz. I'll let you read that question. And it's about the phlebitis scale. You definitely need to know your different levels on the scale. And then there's your answer. And these are just some potential contamination sites of vascular access devices. So always be thinking about all the different ways that we can cause contamination and inadvertently cause a bacterial infection. And here's just a few pictures of the top pictures, an infection. The top two have infection actually, and the bottom has hematoma, some bruising. Thanks.